Ibrutinib seems to be an extremely interesting drug in the context of chronic lymphocytic leukemia. Can you paint in for me some of the reasons why it's interesting and why potentially you were looking at it in the first place?
Ibrutinib is certainly a very unique drug and is a game changer in the treatment of CLL. There are two aspects that will be very, very attractive to you. First is the biology of how it works. And the second piece is, of course, the efficacy and how good it has been for patients. Looking at the biology, the leukemia cells like to have signals from its environment. And the environment provides these signals that give survival, longevity of life to the cancer or the leukemia cells. And these are, think of it as a very electrical kind of a signal. So once these signals come down to the core of the cell, it allows these cells to develop biological processes that sustains them. Now, ibrutinib clips or interrupts these signaling pathways that the cell has with its outside. And that interruption leaves the cell or renders the cell very susceptible to death.
Now, it is therefore quite specific, but you already had relatively targeted therapy with rituximab and bendamustine. What were you trying to do in this study that you've now published?
So this particular study was designed to see if a targeted therapy like ibrutinib can be effectively combined with existing other therapies or chemoimmunotherapy. So this is a unique study, unique combination, because you have a very nicely, as you pointed out, an immunotherapy component to it, which is rituximab, a chemotherapy component to it, which is bendamustine, and then the newest, very specific signaling inhibitor that is mixed together. So it's a very unique combination for the first time in CLL.
So could you tell me what you did in the study?
This is a phase 3 double-blind randomized study where chemoimmunotherapy or bendamustine rituximab was compared with both that combination with ibrutinib, and it was controlled with a placebo. Basically, the idea was to see whether ibrutinib can enhance the progression-free survival.
Right, so standard therapy plus or minus ibrutinib?
Absolutely, in a placebo-controlled fashion.
What happened?
And we found that the primary endpoint of the study was, can these patients have a durable and longer remission induced by the chemoimmunotherapy? And we found clearly, yes, ibrutinib substantially added to the progression-free survival benefit to these patients, and it reduced the risk of relapse or death by 80%, and it reduced the risk of death by itself by about 37%. It was so effective that on the interim analysis, it was deemed that those patients who have progressed on the placebo arm or the control arm were allowed to go on to receive ibrutinib. And 31% of those patients actually did that.
Was there a downside, though, in terms of any toxicity?
There was no significant or untowards or unanticipated side effects. Clearly, bendamustine, rituximab, and ibrutinib have their own toxicity profiles. And what we saw in this study was there's no untowards effect of the triple combination. So it was very effective, anticipated side effects, and great results.
What then are the immediate clinical implications for patients who are relapsing or refractory to standard therapy with bendamustine and rituximab?
Very, very important. So, of course, every research at this scale and with so many countries and investigators and patients involved should mean, or the anticipation it should have it should have an impact on what the patients are going to see in their treatment paradigm. What has happened as a result of this study is that first thing we have been able to confirm in a second phase 3 trial that ibrutinib is actually a very effective drug for CLL patients. This is in continuation with a previous phase 3 study that was reported by Dr. John Bird. And so this study, again in a randomized fashion, proves that ibrutinib is effective. That's number one. Number two is the fact that it prolongs progression-free survival and enhances the chance of going into a remission. So those are very, very important points. In the present management period for relapsed CLL, where it's not a curable disease, the goal is to prolong remission duration. And this study proves that if patients are being treated for relapsed disease with chemotherapy or chemoimmunotherapy, they need to be given ibrutinib with the combination.
Now, how do you choose your patients, though? Because patients with chronic lymphocytic leukemia vary quite a lot.
Absolutely. Great point. This is a heterogeneous disease. We select patients' therapies based on their genetic, their ability to tolerate, their age, their personal goals, what do they want to achieve. 78 years old may have a different tolerability or preference of treatment versus a 35 years old. And so there are multiple factors that go into this in selection of therapy. But one thing is clear, whether it be young, old, genetically aggressive disease or less aggressive disease, ibrutinib seems to be effective in all.
Could you, do you think, use the drug earlier, initially with this triplet therapy?
Ibrutinib has made an impact in the relapsed CLL. The encouraging news of its tolerability, ease of giving, and the durability of response, plus the fact that you can give this therapy for so many years without cumulative toxicity, has now probed us to ask the question, should it be the number one treatment to start with? Those clinical trials are ongoing.
And could you give it as monotherapy or perhaps with just one extra drug?
Again, that also is a question that is being explored. There are two important aspects to it. Can it be given? Yes. Tolerability, toxicity-wise, yes, it can be given as a single agent, has been. It's prescribed right now. Should it be given? If we are aiming to cure this disease, if we are aiming to push patients into complete remission, undetectable disease, then one thing we know about ibrutinib that perhaps in the relapse setting, that chance is less. So combination with other drugs, newer drugs, is very, very important question that we need to answer.
Right, briefly then, what are the clinical take-home messages for cancer doctors all over the world coming out of this?
That what we saw as the initial signal of efficacy and tolerability of ibrutinib in relapsed CLL patient is now endorsed with a large phase 3 second trial. So the second thing is the toxicity signal was not alarming or not unanticipated that we should defer away. Third, if they are going to give chemoimmunotherapy with BR to patients for their treatment of relapsed CLL, then perhaps the standard has now changed from this particular trial into a chemoimmunotherapy BR plus ibrutinib.